Have you ever thought about what happens when the human body just decides to pull the emergency brake?
Right, like a total physiological halt.
Exactly. Not slowing down, not shifting gears, but just a sudden violent stop. I mean, we generally view the body as this relentless machine, right?
Oh, for sure. Always striving for homeostasis.
Yeah, always pushing forward to keep all the systems online. But things change drastically when the body's hormonal engine completely hits the brakes.
It's a massive shift.
And that can happen because of, natural inevitable aging, or because the brain suddenly perceives this massive threat to your very survival.
When that brake is pulled, it completely rewrites the rules of how the body functions on a cellular level.
Which is exactly what we're getting into today. So welcome to this deep dive.
Glad to be here for this one.
Our mission today for you, the listener, is to explore the incredibly fascinating and honestly pretty misunderstood mechanics of female reproductive health.
It's a topic that definitely needs more clarity.
We are going to contrast two totally different reasons the hormonal engine stops. So natural menopause and a condition called functional hypothalamic amenorrhea, or FHA.
Two very different pathways to a similar local problem.
Right. And our core focus is going to be analyzing how revolutionary hormone-free treatments, specifically the O-shot, interact differently with your body depending on whether that brake was pulled by age or by stress.
Because regenerative medicine is completely changing the landscape of tissue repair right now.
It really is. And we've got a fantastic stack of sources to guide us through this today.
Some really groundbreaking stuff in there.
Yeah, we are pulling from an FDA pharmacology review on progesterone gels, several clinical studies on platelet-rich plasma, or PRP.
Including that brand new 2025 study from Frontiers in Medicine, which is just wild.
So wild. Plus, we've got functional medicine insights on amenorrhea and a frankly crazy look into the history of cosmetic gynecology.
It's quite the journey.
It really is. Okay, let's unpack this. Because to understand how to fix a deteriorating tissue in the body, we first have to figure out the exact mechanism that, stopped the hormonal signals in the first place.
Right. I mean, you cannot fix the downstream drought if you refuse to investigate what happened at the dam.
That's a great way to put it.
And in the female body, that dam, the master controller of reproduction, is the HPO axis.
Right, the hypothalamic pituitary ovarian axis.
Exactly. It's this continuous communication loop that originates up in the brain.
So let's map out that communication loop for the listener, because it's not just a simple on-off switch, right? It's more of a cascading signal.
Yeah, it's a highly synchronized cascade. It starts in the brain, specifically in the hypothalamus.
Okay.
You can think of the hypothalamus as a metronome. It releases a hormone called GnRH, or gonadotropin-releasing hormone, in a very specific pulsatile rhythm.
Just keeping the beat.
Right. And that steady rhythm is a signal to the pituitary gland, which sits just below it, to release two other hormones.
FSH and LH, right?
You got it. Follicle-stimulating hormone, or FSH, which tells the ovarian follicles to grow, and luteinizing hormone, LH, which actually triggers ovulation.
And then those travel down into the bloodstream.
Yep, straight to the ovaries, which then respond by producing estrogen and progesterone.
Okay, so brain metronome sets the pace. The pituitary sends the chemical messengers, and the ovaries produce the estrogen that actually supports the tissues.
That's the healthy baseline, yes.
But in the two scenarios we're examining today, that cascade gets broken.
Shattered, really.
So let's look at natural menopause first. The sources describe this as a state of ovarian insufficiency.
Right. That is the clinical term. Natural menopause is a gradual, completely physiologic event. The brain is actually still trying to send the signals.
The metronome is still ticking.
Exactly. The hypothalamus is still pulsing out GnRH. The pituitary is still yelling at the ovaries to do their job by pumping out FSH.
But the ovaries just aren't listening.
Well, they've simply reached the end of their functional lifespan. The cellular machinery is just worn out.
So, to use an analogy, natural menopause is basically like a factory peacefully retiring its aging machines.
I like that, yeah.
The manager is still placing orders, but the machines are just offline.
It's a very accurate way to visualize it.
Mm-hmm.
The communication from the top is intact, but the local production has naturally retired.
Right.
But FHA, functional hypothalamic amenorrhea, that flips the dynamic completely upside down.
Which is wild because the sources point out that this is the most common cause of missing periods in otherwise totally healthy young women.
It's incredibly prevalent. And based on functional medicine insights, the ovaries in an FHA patient are perfectly fine.
Right, they aren't aged or worn out at all.
Not at all. The breakdown is happening at the very top of the chain. It's an issue of basic survival biology.
So it's the brain stepping in.
Exactly. In FHA, the hypothalamus itself alters that pulsatile rhythm of GnRH. It slows it down or it just stops it completely.
Because it's sensing danger.
Yes. The brain acts as a metabolic sensor. It's constantly scanning the internal environment, looking at available energy and stress levels.
And in an FHA patient, it just does the math and decides it's a bad time for a baby.
Precisely. It makes a calculated decision conditions are not safe for reproduction.
So taking our factory analogy a step further, FHA isn't the machines retiring, it's the factory manager aggressively pulling the emergency power switch.
Right, because they realize they don't have enough capital to keep the lights on.
Wow.
And in this case, that capital is cellular energy.
Right, so what actually triggers that manager to pull the plug?
FHA is typically triggered by a triad of factors. First, you have a severe energy deficit, meaning the body is burning far more calories than it's taking in.
Like underfueling.
Exactly.
Yeah.
Second is excessive physical stress, like extreme athletic training.
Okay, and the third?
Immense psychological stress. When you are highly stressed, your body just floods with cortisol and corticotropin-releasing hormone, or CRH.
And the sources mentioned animal models about this, right?
Yeah, they show that high levels of CRH directly inhibit the secretion of GnRH in the brain.
It is genuinely incredible to realize that your brain is constantly running this background math application.
It really is.
It's tallying up the calories you eat, the miles you run, the stress of your job. And if the math shows a steep negative balance, the brain just determines you lack the biological resources to sustain a pregnancy.
It just shuts down the reproductive system entirely to conserve baseline energy for your vital organs.
Which makes sense.
A brilliant evolutionary survival mechanism. I mean, if you are starving or running from a predator, you shouldn't be reproducing.
Right, you need to survive first.
But the local fallout from that survival mechanism is severe.
Right, because the estrogen is gone.
Exactly. Whether that estrogen drop is caused by the ovaries retiring in menopause or the brain pulling the plug in FHA, the localized tissues in the pelvic region suffer immensely from that sudden hormone deprivation.
Which moves us past the systemic triggers and down to the localized reality.
Right.
When estrogen vanishes from the bloodstream, what actually happens to the cellular architecture down there?
Well, we have to look at a condition called GSM. That stands for genitourinary syndrome of menopause.
And the medical community officially adopted this term to replace the older one, right? Vaginal atrophy.
Yes.
The sources make a point of highlighting that name change. Why did the terminology need an upgrade?
What's fascinating here is how many diverse tissues depend entirely on this single hormonal signal.
It's not just one area.
Exactly. The old term implied that the lack of estrogen only affected the vagina. But GSM accurately reflects that the drought impacts the vulva, the urethra, and the bladder as well.
Wow, the bladder too.
Oh, yeah. Estrogen acts as the structural lifeblood for all of these tissues. It dictates blood flow, it maintains the thickness of the tissue walls, promotes elasticity, and drives moisture production.
So by removing estrogen, you are essentially pulling the load-bearing pillars out from under the tissue.
That's a perfect way to visualize it.
Yeah.
The structural integrity just collapses.
That sounds awful.
It is. The epithelium, which is the protective lining of the tissue, it thins out dramatically.
And I imagine that causes problems with friction and things like that.
Major problems.
Hmm.
It loses its crucial barrier function, making the area highly susceptible to microtears and infection.
Oh, wow.
And furthermore, the Bartholin glands, which are responsible for providing lubrication, they drastically decrease their secretion activity.
So everything just dries up.
Yes, which results in severe debilitating symptoms. Women experience dyspareunia, which is painful sex, along with chronic burning, itching, and an increased risk of urinary symptoms.
Like what kind of urinary symptoms?
Overactive bladder, recurring UTIs, things like that.
It sounds incredibly uncomfortable and, frankly, completely life-altering.
It can ruin a person's quality of life.
So if these specific tissues are deteriorating because they are starved of estrogen, I mean, the obvious medical solution would just be to give the estrogen back, right?
You'd think so, yes.
But systemic hormone therapy comes with risks. So how has the field traditionally handled local delivery? Like, how is that evolving?
The traditional route has been to apply the hormones directly to the starved tissue.
Like a cream.
Right. For instance, our sources highlight an FDA pharmacology review of a prescription product called Creno.
Okay, Crenone, that's a bioadhesive vaginal gel, right?
Yeah.
Usually prescribed for secondary amenorrhea.
Exactly.
But how does putting a gel on the tissue differ functionally from just, taking a hormone pill?
It really comes down to cellular delivery and avoiding the liver.
Okay, break that down for me.
So Crenum delivers progesterone locally using a very clever water-insoluble polymer called polycarbophil.
Polycarbophil.
Yeah. This polymer has a slightly negative ionic charge, and that negative charge allows it to form hydrogen bonds directly with the epithelial cells of the vaginal wall.
So it, like, literally sticks to the wall.
It literally anchors itself to the tissue for 48 to 72 hours, just slowly releasing the hormone.
So by sticking it directly to the wall, you're totally bypassing the digestive tract.
You avoid what pharmacologists call first-pass metabolism.
First-pass metabolism, meaning the liver.
Right. When you swallow a hormone pill, it goes through your stomach and straight into your liver.
And the liver just chews it up.
It breaks a massive amount of it down, creating metabolites that often cause systemic side effects.
Like what?
Oh, extreme drowsiness, mood fluctuations, things you really want to avoid.
Yeah, nobody wants that.
So by anchoring a polymer directly to the target tissue, you achieve a highly concentrated dose right where it's needed with just a fraction of the systemic absorption.
Which makes perfect logical sense for delivering hormones.
It does.
But if bathing the tissue in localized hormones only masks the structural problem as long as you use the gel, I mean, how did medicine pivot to actually rebuilding the damaged infrastructure?
Well, that puzzle led an unconventional pioneer to look at a completely different tool.
And we are talking about Dr. Adrian Gaspar, right? The Argentinian gynecologist.
Yes, exactly. Over a decade ago, he observed how dermatologists were using lasers to rejuvenate aging skin on the face.
Like for wrinkles and stuff.
Right. The lasers stimulated underlying collagen production. So he hypothesized that the exact same principle could be applied inside the vagina to treat the thinning tissues of GSM.
Okay, I have to pause and push back on this because the visual is just alarming.
It sounds extreme, I know.
Right. I mean, a doctor decided to take a medical CO2 or erbium laser, a tool normally used in surgery to vaporize tumors or like cut through fascia, and fire it into one of the most highly sensitive nerve-dense areas of the human body.
Yes.
On paper, that just sounds incredibly reckless.
And the broader medical establishment shared your skepticism initially, believe me. It sounded totally counterintuitive to apply destructive energy to tissue that is already fragile.
Exactly.
But Dr. Gaspar understood the nuances of tissue physics. He wasn't using a continuous ablative beam to just burn away tissue.
Okay.
He was using precise fractional laser energy on non-fibrotic tissue.
Meaning he wasn't destroying the tissue, he was just irritating it.
More than irritating, actually, he was inducing highly controlled microtrauma.
Microtrauma.
Right. When you create microscopic thermal injuries in healthy tissue, the body immediately mounts a massive biological defense.
Like sending in the troops.
Exactly. The immune system floods the area with fibroblasts, which are the cells responsible for generating new collagen.
Okay.
It forces angiogenesis, which is the creation of new blood vessels, to repair the damage.
Ah, I see.
So the laser essentially tricks the body into launching a healing cascade, which plumps, thickens, and restores the tissue architecture.
So Dr. Gaspar proved that if you could just trigger a localized emergency response, the tissue could physically rebuild itself without even relying on estrogen.
Which was a massive breakthrough.
But using lasers still relies on thermal damage to force that reaction.
True.
What if you didn't have to burn the tissue to get it to heal? Like, what if you could just directly inject the biological signals that tell the tissue to grow?
Now you are crossing the threshold into regenerative medicine.
Let's go.
And that brings us directly to platelet-rich plasma therapy, commonly known in this context as the O-shot.
Okay, here's where it gets really interesting, because the mechanics of the O-shot sound a bit like science fiction.
They kind of do.
But it's an in-office procedure happening globally right now. So break down exactly how we get from a blood draw to literal tissue regeneration.
So it is an entirely hormone-free autologous treatment.
Autologous meaning from yourself.
Exactly, meaning it comes purely from your own body. The physician draws a small amount of your blood, exactly like a standard physical.
Just a quick blood draw.
Yep. That vial is immediately placed in a centrifuge.
Okay, so it spins it down.
Right. The extreme spinning separates the red blood cells, which we don't want, from the golden plasma and the platelets, which we desperately want.
Okay, so we all know platelets are the first responders for clotting when you get a cut.
Sure.
But in regenerative medicine, we're not trying to stop a bleed here. We are after what's inside them, right?
Exactly. The clotting is just their first trick. Platelets are essentially microscopic cargo ships, and they are just packed with growth
Growth
factors.
factors.
Yes, we're talking about specific proteins. For instance, VEGF, which is the body's blueprint for building brand new blood vessels, and TGF-beta, which acts as a biological foreman commanding tissue repair.
I love that, a biological foreman.
Right. So when this highly concentrated plasma is injected back into the vaginal and clitoral tissues, the platelets degranulate.
Degranulate, meaning they open up.
Yes, they open up and release all these growth factors directly into the starved tissue.
Wow, so it's like sending the construction crew directly to the site without having to cause the thermal trauma of a laser first.
Exactly. You skip the injury part. The growth factors stimulate pluripotent stem cells in the local area.
Wait, stem cells are already there.
Yes, these are essentially blank slate cells that can transform into whatever type of tissue is needed.
That's amazing.
And the result is massive collagen production, enhanced blood flow, and crucially, the regeneration of sensory nerve endings.
Which explains why the clinical applications for this are so broad.
They are incredibly broad.
Because our sources show the O-shot addresses stress incontinence, which is, leaking when you sneeze or jump, by literally rebuilding the pubocervical fascia.
The connective tissue supporting the bladder, yes.
Right. And it also rejuvenates the Skene's glands, which are crucial for natural lubrication, so it directly combats vaginal dryness.
And the clinical efficacy data is just incredibly robust.
Tell me about the Longdom study.
Right, so a pilot study published in Longdom tracked 68 women. And these women ranged in age from 32 all the way up to 97.
97.
Yes, and after just 2 sessions, 94% of the participants reported significant satisfaction with the functional results.
94% is huge. But I think the truly disruptive data comes from the brand new 2025 study from Frontiers in Medicine.
Oh, absolutely.
Because they didn't just test PRP against a placebo, they pitted it directly against the undisputed heavyweight champion of vaginal atrophy, topical estrogen.
It was a highly ambitious trial design. I mean, for decades, as we discussed with Crenone, topical hormones have been the gold standard.
Or go-to treatment.
Right. But the Frontier study revealed that by week 8, the PRP injections actually outperformed the topical estrogen.
Outperformed it.
Yes. In improving dyspareunia, decreasing the sensation of burning, and elevating overall sexual function scores.
So PRP beats synthetic estrogen.
Yes.
Using absolutely nothing but the patient's own concentrated blood.
Just their own plasma.
And presumably, because it's your own blood, you completely bypass the systemic hormone risks that, say, breast cancer survivors have to navigate.
That is a critical advantage. There are 0 systemic hormone side effects because you are solely utilizing autologous plasma.
It's just you.
Right. There is no risk of an allergic reaction, and your immune system will not reject it. It is your own biological material merely concentrated and relocated.
And this brings us to the absolute core focus of our deep dive today.
Yes, the big question.
We've established that the O-shot works incredibly well for tissue starved of estrogen, but we need to answer a very specific medical mystery.
Which is?
A clinical FAQ from the Women's Health Clinic specifically asks, how does local tissue responsiveness to an O-shot differ in premenopausal women with hypothalamic amenorrhea versus natural menopause?
And this raises an important question, because it forces us to stop looking at the localized pelvic symptom in a vacuum.
Right, zooming out.
We have to start evaluating the patient's entire systemic ecosystem. So let's analyze the menopausal patient first.
Okay, so going back to our factory analogy, this is the patient where the ovaries have simply retired, but the manager up top is otherwise totally fine.
Correct. In natural menopause, the patient is generally systemically healthy.
Right.
Their body is functioning appropriately for their chronological life stage. They simply have an irreversible, localized estrogen deficiency in those specific tissues.
Okay.
Because they're systemically healthy, their blood plasma is a fully stocked construction crew.
Good workers, good tools.
Exactly. It is rich, robust, and packed with high-quality growth factors.
So when you draw their blood, spin it down, and perform the O-shot, you are injecting a highly capable, well-resourced healing cascade.
And the therapy works brilliantly for them. It completely bypasses the need for estrogen, utilizing those healthy local growth factors to rebuild the tissue architecture independently of the ovarian hormones.
Okay, that makes total sense. But what happens with the FHA patient?
Ah, right.
The one where the brain pulled the emergency brake because the body is starving or overexercising and just drowning in stress.
This is where regenerative medicine crashes into a severe systemic roadblock.
Oh, wow.
Because the FHA patient is in an active survival crisis. They are suffering from a chronic negative energy balance.
So they don't have the fuel.
Right. Their leptin levels, which signal energy availability, are completely depleted, and their stress hormones, cortisol and CRH, are chronically elevated.
And how do those systemic lifestyle factors physically alter the biology of their blood? Like, does it actually change the blood itself?
Profoundly.
Yeah.
The clinical FAQs from our sources highlight that these systemic crises dramatically degrade the structural quality of a patient's plasma.
Right.
Yeah. If an FHA patient is severely underfueling, they might be suffering from severe iron deficiency anemia, for example.
Okay.
And when cortisol is chronically high due to stress, it induces systemic oxidative stress throughout the body.
Which sounds bad.
It is. This oxidation actually alters the lipid composition of the platelet membranes themselves.
Wait, so the stress is actively changing the physical structure of the platelets in their bloodstream?
Yes. The outer membranes of the platelets become rigid instead of fluid.
They stiffen up.
Exactly. So when you concentrate those platelets and inject them into the starved tissue, they struggle to degranulate.
They can open up.
Right. They physically cannot crack open effectively to release their payload of VEGF and TGF data. So the regenerative cascade is completely blunted.
Wow. So in an FHA patient, you are taking structurally compromised, nutrient-depleted blood, spinning it down, and injecting weak platelets into the tissue.
Yes.
And you're basically hoping for a miracle that the blood is no longer capable of providing.
You cannot out-inject a systemic crisis. For the FHA patient, utilizing an O shot to treat the local symptoms without addressing the severe systemic deficits is just an exercise in futility.
Because the root cause is still there.
The root cause, the caloric deficit, the extreme physical exhaustion, the crippling psychological stress, all of that must be corrected first.
Right.
Otherwise, their own blood literally lacks the biological capital to heal them.
That is it's a huge takeaway. If you are someone who pushes your body to the absolute brink, underfueling, overtraining, never sleeping, it's vital to understand that you aren't just making yourself tired.
Not at all.
You are actively altering the structural integrity of your own blood cells, stripping them of their intrinsic ability to heal your tissues. You have to treat the root mechanism, not just chase the symptoms.
It is the exact same flaw as giving birth control pills to an FHA patient.
Right, which happens all the time.
All the time. The synthetic hormones will trigger a withdrawal bleed, creating the illusion that their period has returned and they are healthy.
But they're not.
No, it is just masking the localized symptom, while the severe brain-level suppression continues to wreak havoc on their bone density and cardiovascular system.
It's a Band-Aid on a bullet wound.
Exactly.
Yeah.
And the logic perfectly translates to regenerative medicine. If you don't fix the patient's physiological inputs, their own blood cannot save them.
It has been a truly fascinating journey today.
It really has.
We started with the hypothalamus pulling the emergency brake on reproduction, throwing the whole system into the survival mode of FHA.
A profound metabolic shift.
Yeah. And then we explored the localized structural collapse of the tissue during GSM when the estrogen disappears.
Right.
And we've traced the incredible evolution of treatment moving from localized bioadhesive progesterone gels like Crenone to Dr. Gaspar utilizing controlled laser trauma to force a healing response.
And finally arriving at the frontier of PRP.
Yes.
Harnessing the raw biological blueprints hidden inside our own platelets to physically rebuild blood vessels, nerve endings, and collagen.
It really reinforces the reality that true medicine requires understanding the why before applying the what. You have to know why the engine stopped before you can figure out how to effectively repair the broken parts.
And the O-shot has proven in rigorous clinical trials that our own concentrated blood can regenerate and heal damaged tissue better and faster than the synthetic hormones that originally built those tissues in the first place.
Which is mind-blowing.
It is, and it leaves you with this thought. If our own blood contains that much latent, untapped regenerative power, just waiting for the right biological signal to be activated, what other inevitable aging processes in the human body could we completely reverse if we just figured out how to properly redirect our own internal resources?
Wow. It really makes you rethink the ceiling of human longevity.
It certainly does.
Well, thank you for joining us on this deep dive. Until next time.